Hi, everybody. Welcome back to the intern and associate trainings. The second semester of the year, we are doing trainings every other week. So you will have two trainings a month through the end of your internship time. For folks who are associates, this is usually through the beginning of April. And we will redo these trainings again starting in the fall. My name is Dr. Valerie Leva. I'm a clinical supervisor with BHRS. I'm also a soon to be retired faculty member of the MSW program at Cal State Stanislaus. And today, this is a diagnosis workshop. There are a number of diagnoses that have overlapping symptoms, and sometimes it's hard to determine, is it this or is it that? Today, in particular, we're going to talk about PTSD versus bipolar 1 and 2 versus borderline personality disorder. Then we're going to talk about ADHD versus PTSD in children and adults. Then we're going to talk about schizoaffective disorder, bipolar type versus bipolar disorder with psychotic features. And if we have time, we'll talk about depression versus dementia versus delirium. This is one that you'll have to tease apart if you're seeing somebody who's in crisis, particularly an older adult, or if you're seeing somebody in the hospital. As always, here are the rules for trainings for BHRS, which are not that pertinent while we're doing this online. So let's go to the learning objectives. The learning objectives here are to effectively identify symptoms and delineate between each of the disorders that we've listed here, and then identify how these disorders are misdiagnosed based on factors such as gender, race, and other cultural and demographic issues. There's a certain tweak to each one of these as we go through them. So I want you to think for a minute, which of the diagnosis pairs do you struggle with the most? Is it the overlapping symptoms of ADHD and PTSD? Is it the overlapping symptoms of bipolar versus PTSD versus borderline? That tends to be a big one. So think a minute about which one of these do you struggle with the most in diagnosis? So we're going to jump right in, looking at PTSD versus bipolar disorder versus borderline personality disorder. Which one is it? So it's important to remember what the primary features are and what the diagnostic criteria are for each of these disorders. So, got something interesting here I have to take out of the PowerPoint. For PTSD, there is exposure to an actual or threatened death, serious injury, or sexual violence, and it has to be experienced, witnessed, hear about it happening to a close family or friend, or to be a first responder who gets exposed to this daily. We talk sometimes about big T trauma and little t trauma. There are traumas in life for everybody. When we talk about big T, capital T trauma, we're really talking about somebody who has this index trauma in PTSD, exposure to actual or threatened death, serious injury, or sexual violence, experienced in one of these four different ways. There are many other traumas that people experience. It just doesn't meet the criteria for PTSD. So then you would use other specified trauma disorder in your diagnosis. But for categories of symptoms in PTSD are intrusive symptoms such as flashbacks or nightmares about the experience, avoidance symptoms, avoiding things that trigger memories of the trauma, negative alterations in cognitions and mood. And this tends to be the category that gets confused with borderline and bipolar features. This is where people have a negative view of the world, they have negative emotions. And then the last one is alterations in arousal and reactivity. So this might be hypervigilance, a startle response, anxiety, etc. So think about PTSD from that perspective. It is primarily a trauma disorder. When we move to bipolar disorder 1 and 2, this is a mood disorder. So that is the main feature of it. For bipolar 1, the person has to experience a manic episode. That's a distinct period, a very distinct period of abnormally and persistent elevated, expansive, or irritable mood, abnormally and persistently increased activity or energy, and it lasts 1 week or less if a hospitalization is required. This is a very distinct difference in their daily functioning, and it is acute onset. It happens from day one to day two. It's not a long, gradual onset. It is a very acute onset, and it is a very distinct period different from the rest of their functioning. Bipolar 2 is consists of a hypomanic episode, same as a manic episode, but only lasts 4 days. And the person may or may not have experienced a major depressive episode. Again, these are distinct periods of time where the person's functioning is different than their previous functioning. So it's really important to remember that. When we talk about borderline personality disorder, we're talking about a pattern of instability of interpersonal relationships, self image, affect, and high impulsivity. This is not an acute onset like a manic episode or a depressive episode. It does not necessarily have the index trauma that you see in PTSD. So these are the things that we have to remember that are different from each one of these between a trauma oriented diagnosis, a mood diagnosis, or a personality disorder diagnosis. Sorry about that. So, how to clear up the confusion between these three? One of the basic things of helping to split these apart is really understanding the difference between mood and affect. Mood is the internal emotional state experienced subjectively by the client. So when we ask somebody how do they feel, they're going to tell us what their mood is. This is what they feel like on the inside. Mood doesn't change minute to minute or hour to hour. Mood fluctuates over days, for some people, weeks and months if they have difficulties with something like a major depressive disorder. Mood is inside, affect is outside. It's what we see in people. So it's an external display of an emotional state that can be observed by other people. In PTSD, you'll see changes in mood, right? That those negative cognitions are part of a mood change, and they are going to be long-term changes, days and weeks. And they tend to skew negative. They're not going to be people feeling grandiose and happy about themselves in the world. In PTSD, the mood changes take a longer period of time, and they tend to be more negative. In bipolar 1 and 2, the changes in mood last days, not hours. So, and usually not long term either. So changes in mood are going to be a distinct, particularly with mania and hypomania, it's going to be a very distinct change in mood from day 1 to day 2. So you're just going to see that abrupt change in mood. In major depressive disorder, the mood tends to be more longer term. The depressed mood tends to be longer term, although for the diagnosis, they only have to experience it for oh my gosh, that left my head. 2 weeks, I think. You have to take a look at that. I believe it's 2 weeks. And if they have something called persistent depressive disorder, it's going to be weeks and months. But again, this is what they feel on the inside, not what they're demonstrating on the outside. For borderline personality disorder, this is very different. The emotions that we see in somebody with borderline personality is an unstable affect. So it's their unstable display, external display of emotions, and it can change in minutes to hours. So I think about somebody who might be having a meltdown, who has borderline personality. Perhaps they were not able to get the housing that they wanted, or um, something happened in an interpersonal relationship. This tends to be what causes a meltdown in borderline personality. The person's affect is going to change like that. They could have been okay in the morning and not okay by the time they see you at 2 in the afternoon, or even from noon to 1 p.m. Their affect might change. They might become very emotional, crying, tearful, yelling, agitated and gesturing a lot. And then sometimes if they're able to get what they were unable to obtain, like if you say, okay, I can put you in a motel for a day, you'll see them start to calm down. And it's not a deliberate um, display of emotion. It's not necessarily manipulative just to get what they want. It's part of the disorder. And that can be why sometimes it's very challenging to see people with borderline personality disorder, because they have these frequent unstable affect episodes that folks tend to call meltdowns. And one of the goals in treatment is to provide them with the skills to obtain distress tolerance and emotion regulation. And that's why that treatment is so much helpful. So, clearing up the confusion, know the difference between mood and affect. Mood is internal, affect is what we can see on the outside. And people with borderline personality disorder tend to have large displays of affect. People with a mood disorder is going to have, particularly with mania and hypomania, the mood is going to change abruptly from one day to the next. People with uh, PTSD tend to have the longer periods of negative mood that skews negative. Another thing in clearing up the confusion between these three disorders is the time considerations. How long have the symptoms been present? In PTSD, the symptoms last months and years frequently, but the onset is after a specific episode of actual or threatened death, serious injury, or sexual violence. For folks who struggle to identify what was the index trauma, particularly people that experience trauma in childhood, or the trauma doesn't raise to the level of the index trauma on criterion A for PTSD, sometimes it's hard to identify when the symptoms started. So I always do a timeline with folks. But know that this is a long timeline. For people with bipolar 1 and bipolar 2, it's either 7 days or 4 days. Typically does not require hospitalization for bipolar 2 for a hypomanic episode. But these are abrupt and acute changes in mood. And so it's going to be a much shorter timeline than PTSD or borderline personality. For borderline personality, the symptoms typically last for years, and the onset is gradual with no specific onset. So no specific episode. It just kind of grew out of their experience of disappointment, abandonment, trauma, etc. And the symptoms may be episodic. They can go away on their own, but they don't stay away. So again, look at the timeline. Is it a few days? Is it a week? Is it months and years? When was the onset? Was it onset after a very specific traumatic event? Or did it just gradually happen as the person grew into adulthood? Another way to clear up the confusion between these three diagnoses is to look at episodes of impulsivity, self-destructiveness, or suicidal behavior. For somebody with PTSD, there needs to be that index trauma. So, did the impulsivity, self-destructive, or suicidal behavior happen before a trauma they've identified? Maybe it's not just PTSD. Maybe it's something else. Maybe it is borderline personality disorder. You can have both of these diagnoses at the same time. If the impulsivity, self-destructiveness, and suicidal behavior is encapsulated in an acute manic or hypomanic episode, so look at the 4 to 7 days period, and they have periods of time in between where they're fine, then that is bipolar disorder, either one or two. The other consideration is you always have to screen for medications, supplements, energy drinks, alcohol, and illegal drugs. Excuse me. It's going to be very hard to clean up these diagnoses if someone's intoxicated. So we always have to make sure we try to get folks to clear through these substances before you can do a good timeline. And very frequently, you're going to have to rely on collaterals for timeline if the person cannot describe their experiences themselves. There are also some standard misdiagnosing of bipolar disorder, PTSD, and borderline personality disorder. Sometimes there are assumptions made due to gender. Although more women are diagnosed with borderline personality than men, it's unclear if this is accurate. Does it really run more in women than men, or is it due to cultural assumptions about women's behavior, particularly about being emotional, impulsive, etc.? There's also a trend in thinking that trauma, poor attachment, and childhood abuse is at the heart of borderline personality. So if someone comes to you with borderline personality disorder, also screen for PTSD, it is possible to have both. So I've dropped in some resources in between each of these sets. So there's a very good info sheet on bipolar versus PTSD versus borderline personality that's suitable to use for clients, located at the link I've indicated here. And then there's a really good visual diagram and info sheet on differences between chronic PTSD and borderline personality disorder. Take a look at that. I tried to draw one of those Venn diagrams with chronic PTSD, borderline, and bipolar, and I just couldn't make it work. And no one else has either. I haven't been able to find one. I've been looking for it. So again, if you see folks with these disorders or commonly with these disorders, which we do at BHRS, particularly in adult services, look at the differences and how to clear up the confusion. Normally, I would have a break. We'd have a chat about what questions you have, what makes sense to you, what doesn't make sense to you. What I'd like you to do is take a couple of minutes, review these slides on these three disorders, and write down questions that you have. Maybe you have about a particular client. And then I'd like you to take those questions to your supervision, to either your individual and group supervision or your staffing, so that you can staff cases knowing a little bit more about how to make the distinguishing between these different disorders. So take a minute to do that before we move on. Okay, deep breath, because now we're going to talk about attention deficit hyperactivity disorder versus PTSD. Which one is it? And I got really interested in this about 15 years ago when I was head of service for the Child Abuse Prevention Council in Stockton. As a clinic, as a mental health clinic, we decided to, because of the population that we saw, which were kids who'd been in foster care, kids who'd experienced a lot of changes and disappointments in their lives, we decided that we were going to screen every kid we saw for PTSD. We were going to automatically screen everybody for that. And this was before the CANS was widely available. I mean, before some of the other screening features were, because our experience was that teachers were referring kids to mental health because they said they can't sit still in class, they're inattentive, they can't maintain their emotion regulation very well. Go get some Ritalin or some of the other drugs. And as you all know, that doesn't work for everybody because they don't have ADHD. If a stimulant like Ritalin does not work for somebody who has those symptoms that look like ADHD, if it hasn't worked in a week, it's not going to work for them in general. Always check with a psychiatrist or a medical provider when you have questions about that. But that's been the observations that most people have made. So let's look at the diagnostic features of each of these diagnoses. For ADHD, it's a persistent pattern of inattention or hyperactivity and impulsivity that interferes with functioning or development. There's the inattentive type, and then there's the hyperactive impulsive type. Now, we've just gone over PTSD, right? You have to have that index trauma to use the PTSD diagnosis. If you don't, you use other specified trauma disorder. And many children will not be able to recall or describe an index trauma. If we experienced an index trauma, a threat to our life or someone else's life, before we had language, we're not ever going to be able to describe it with language. People will have somatic memories of it. They'll remember what it looked like or smelled like or heard. That's why scent and taste memories are so powerful because we still have those memories even before we had language. So it's important to remember, particularly working in children's system of care or working with adults who had a lot of childhood trauma, that they may not be able to identify an index trauma. So let's clear up the confusion between these two. There's a significant overlap in symptoms between ADHD and PTSD, particularly regarding impulse control, memory, sensory issues, attention concentration, emotion regulation, distractibility, restlessness, and forgetfulness. A lot of these symptoms fall into the PTSD negative alterations in cognitions category. So take a look at these, looking at both pages in the DSM, right? Which one is it? Is it just the overlap, or do I have all the other symptoms on the side? So look for key differences. In PTSD, they might have all of these impulse, restlessness, forgetfulness, or regulation symptoms, but also look for an index trauma if you can identify it. Look for the avoidance behaviors. Are they avoiding triggers that remind them of bad experiences they've had in the past? Look for the negative beliefs about self and the world, and look for the hypervigilance. These are not symptoms of ADHD. So if the person comes in looking like, unfortunately, the typical kid that can't sit still, that can't concentrate, that can't focus, screen for the other symptoms of PTSD and see if it's PTSD. It is possible to have both, but if it's PTSD, you've got a whole different treatment path to follow than if it's just ADHD. So for ADHD, another key symptom is symptoms present since early childhood, right? So this is going to manifest itself. It's usually observed when a child gets into day-long kindergarten or first grade when they have to sit in a chair all day. Um, If the child seeks novel experiences or unusual experiences, if they're creative and if they have the ability to hyper focus on a task, this is more ADHD than PTSD. People with PTSD don't have that ability to hyper focus. That's a key feature of ADHD. They can hyper focus on one thing and do that one thing as long as they don't have distractions around them. So that's a simpler way to look at the symptom groups and see which one your client is experiencing. Okay. Another consideration in particularly with PTSD, because we work with a clinical population that includes people with serious mental illness, history of foster care, homelessness, exposure to community trauma, chronic substance use, etc. I would always assess for PTSD, even if the person does not identify that as a primary concern. Always obtain information about current use of medications, alcohol supplements, energy drinks, and illegal drugs, um, because that is going to change the presentation of the person in the moment when you're interviewing them. And in recent years, I've started asking screening questions about head injuries because we see a high homeless population, people exposed to violence in the community, or kids have been exposed to trauma in the home or domestic violence in the home, or you're seeing an adult who, as a kid, was living in challenging circumstances that had a lot of trauma. You don't know whether or not they've had a head injury, and you don't know how much that might be affecting their personality, their executive functioning, their impulsivity and restlessness, etc. So there's a simple, I forgot what these are called, memory aids here. It's called HELPS, helps. Have you ever hit your head or been hit on the head? Have you ever gone to the emergency room because of a head injury? Did you ever lose consciousness? Noting that not everybody who has a brain injury has lost consciousness. Do you have are you having cognitive or social problems in your daily life? And did you experience a significant sickness following a blow to the head or debris falling on you or being in an auto accident where you hit your head? I myself have had a head injury because of an auto accident. And I did notice changes in cognition after I had that accident. It's been about 15 years now, and I do still have trauma with word recall. And so I do have a lingering cognitive delay a little bit because of that. Um, I was fortunate that it didn't change my personality. It was where I was hit in the head and how I was injured. But for some people, it can be an abrupt change in personality. So do a timeline with them. Can they remember when they had any kind of head injury, whether they received services for it or not? And did they notice a change in behavior, a change in their functioning after that? So this is not something that is widely done at BHRS, but I have started doing it myself because of just a high incidence of unreported head injuries in folks, and that can cause challenges in their behavior. If the person responds yes, then I would refer them back to their primary care physician for further assessment because it would go into primary care at that point for medical assistance. So there are tons of misdiagnoses of ADHD versus PTSD. Um, Many children, as I said, are diagnosed with ADHD because of the symptoms related to impulse control, attention, concentration, etc. Um, and again, always screen youth for trauma disorder or an adult who, as a youth, was exposed to domestic violence or was in foster care. You might not have enough information about an index trauma, but can shift the perspective of the youth, and particularly in the eyes of the educational providers and foster families, if they're seen as not just a misbehaving kid or a kid with ADHD, but if they really have PTSD, this shifts our path of treatment, and it also shifts perspectives of the youth and the families. So here's some resources, and there are now a ton of resources on the overlap of ADHD and PTSD. I am very fond of the blog called Misdiagnosis Mondays. I just went on it as I was preparing for this, and I see that she's starting to monetize what she's done on her website, which kudos to her, right? She is a PhD psychologist who also has neurodivergence. And so she's done a lot of the work around it. Let me see if I can click on this because I really would like to show you um, one of the ways in which she has developed materials for us to use. Okay. So here's her misdiagnosis Monday, ADHD versus PTSD. She does these visuals that shows these are the symptoms over here of ADHD, and these are the symptoms of PTSD, right? And then the middle is the overlap. And a lot of times I've shown these to clients and to their parents and caregivers, and it's been a big recognition that, oh my gosh, this can be part of both. I'm seeing the middle here. So it's really part of two disorders and not just, as I said, the stereotype of the misbehaving kid, um, or the issue with it's just ADHD and they should get on some meds. Sorry about that. There's a good one pager with a focus on foster children at this link, and I think that that's helpful too. So we're going to take a pause and think about maybe a client you've seen or a client you've seen in the past and had some questions about it. What questions do you have about the overlap between ADHD and PTSD in children and adults? And maybe think of a specific client that you've already got on your caseload and take those questions to your supervision groups or to your care groups in your units. Or maybe even talk about it just with another person who's providing services, such as a BHS or a peer support person. And kind of brainstorm, is it this or is it that? And think about the ways you can distinguish between the two. So take a minute to do that before we move on. Okay. So the third category we're going to look at is bipolar disorder with psychotic features versus schizoaffective disorder bipolar type. Which one? And this distinction is subtle, but it has significant ramifications for our adult population in particular. In 2023, SB 1338, the CARE Act was passed. And it was implemented in Stain County in 2024. This act provides significant funding for treatment for housing for those with psychotic disorder diagnoses. Schizoaffective disorder qualifies, bipolar disorder does not. So it makes a difference what the diagnosis is. So there are some very distinct differences in these two disorders. So let's take a look. Bipolar 1 and 2 is essentially a mood disorder, right? So you either with bipolar 1 have a manic episode, bipolar 2, hypomanic episode, and perhaps a major depressive episode. These are acute, distinct periods of time. They may also have psychotic features. This is a, a category that you can classify with bipolar 1 and 2. The symptoms of psychosis are transient and only present during the course of the hypomanic or depressive episode. They don't have any symptoms of psychosis in between the manic or the hypomanic episode or depressive episode. That's a little more unusual. So think of bipolar disorder as a mood disorder, distinct episodes, and these psychotic symptoms are only present during these distinct episodes. Okay. Schizoaffective disorder, on the other hand, is a psychotic disorder. This is where a person has a baseline of psychosis independent of any mood episodes they may have. So, in order to be diagnosed with schizoaffective disorder, you have to simultaneously meet the criteria for schizophrenia and a major mood disorder. If somebody comes in presenting as having a manic episode and you screen them and they maybe have some psychotic disorders, have they ever experienced the criteria for schizophrenia outside of the mood episode? The answer should be no if you're giving a bipolar diagnosis. For somebody with schizoaffective disorder, they have to meet both criteria, the bipolar 1 or 2 or major depressive episode and schizophrenia. And they must have delusions or hallucinations present for at least 2 weeks in the absence of any mood symptoms. So if they don't have a manic episode, they're not having a hypomanic episode, they're not having a depressive episode, they have to have psychosis symptoms, delusions or hallucinations specifically for a period of 2 weeks, lifetime. Okay. So that's the basic difference. So you can indicate that there's a bipolar type. This is what you use when people have symptoms of mania or hypomania during their mood episodes. So the other criteria, this one is always the hard one, so I have to get it thinking right in my mind. So somebody with schizoaffective has schizophrenia, has a major mood disorder. They have to have a major mood episode for the majority of the time they're actively experiencing symptoms. So that throws people off. So I would say set that one aside. First, you have to see, do they meet the criteria for the mood episode and schizophrenia? And has there been a period of 2 weeks lifetime where they haven't had the mood episode, but they've had criteria met for hallucinations and delusions? Okay. So, how to clear up the confusion? Obviously, obtain a good timeline. And this is hard to do with somebody who's currently having a mania episode or depressed episode and hallucinations and delusions. They're not necessarily going to report information accurately or be cognitively alert enough or grounded enough in reality to give you accurate information. So you're going to have to do some research. You're going to have to go into older records sometimes, and you're going to have to talk to collateral if they have any. Okay. So, bipolar with psychotic features. The distinct episodes of mania or hypomania depression occur with the symptom of psychosis, and there's no psychosis in between these moods. Schizoaffective bipolar type, distinct episodes of mania and hypomania and depression superimposed on psychotic symptoms. That's another way of thinking of it. So there has to be at least one period of 2 weeks, lifetime, in which they have not had the mood symptoms and they have had the psychotic symptoms. Okay. A couple other small things about this. People with bipolar 1 and 2 do not have a flattening of affect. People with psychotic symptoms frequently do. So, person with bipolar, if you're looking at bipolar and they have a flat affect, that's not quite bipolar. Bipolar is grandiose and expansive and elevated or depressed, but not a flat affect, which is no emotional expression. And people with bipolar 1 and 2 typically do not exhibit apathy, which is the anhedonia, the lack or desire to do anything. That's frequently not a part of bipolar 1 and 2. Sometimes it comes with the depression episode, but it's really not typical in bipolar 1 or 2. So those are two other small tweaks you can look at. So misdiagnosis of mood and psychotic disorder. And there is a history of men of color being given harsher diagnoses when presenting with the same exact symptoms as their white counterparts. So there's multiple studies of Black men being diagnosed with schizophrenia when presenting with the same symptoms that white men have, who then are diagnosed with bipolar disorder with psychotic features. So be aware that there's a history of that. And there's a way to avoid misdiagnosis by always, always, always. Every client you see, every assessment you do is go back to your DSM. Always look at the DSM, go down the list of criteria, write your report in that order. A client is experiencing intrusive symptoms of repetitive play in children or distressing dreams. They're persistently unable, they report they're unable to have positive feelings. They have had dissociative symptoms of flashbacks or feeling that they're not there, not in their body. So just go straight down the list and report it by the list. That way you can always show to whoever's reading the report that you've gone through the list. And it also is the way that we help prevent ourselves from misdiagnosing somebody based on biases. Okay, so let's go to resources. There are now a ton of online resources on the overlap between these disorders. So I found a good single page overview that's suitable to give to clients. And the search term I use, differential diagnosis bipolar with psychotic features versus schizoaffective disorder. When we're talking about is it this, is it that, the technical term is called a differential diagnosis. Why are we making this difference between this person and that person? So take a minute, take a deep breath before we move on. And think about clients you've seen who have schizoaffective disorder with psychotic features or bipolar disorder. I'm sorry, schizoaffective disorder bipolar type versus somebody with bipolar disorder with psychotic features. What are the big differences? What is their baseline for psychotic features, for hallucinations and delusions? Do they have those in between these mood episodes? Okay, that's going to be your big distinguisher. Think of a client that you have questions about. Write down a couple of questions you have about that client and what you might take back to your units or take to supervision to discuss. Okay. We do have time to talk for a few minutes about the difference between dementia versus delirium versus depression. Dementia is a neurocognitive disorder. Delirium is a cluster of symptoms that come to the forefront when somebody has an underlying illness that they're experiencing, and depression is a mood disorder. So sometimes it's helpful to think in categories is one way to keep these straight. So the feature is listed on the left, and the disorders are through here. So somebody with dementia, the onset is gradual. This happens over a period of years. The prognosis for them is it's irreversible. We have no treatment, no successful treatment for curing dementia, although there are some medications that slow down the process. The course of it, how does it move through time? How does it look through time? So the course is progressive. So they start with fewer symptoms and build up symptoms and build up symptoms and build up symptoms. Their attention, are they able to attend to you and pay attention and answer a question or two? It's pretty normal um, for people with dementia until they get very progressed towards the end of the disease. Their memory is impaired, both recent memory, because they're unable to store recent memories, and remote memories are impaired sometimes. Although some folks with dementia can recall childhood memories easier than what they had for lunch that day. Their perception, this is kind of grounding in reality. Do they know where they are? Do they know who they are? Do they know where they are? Um, their perception is pretty normal until the end stage of this disease. And their psychomotor behavior is normal, and they gradually lose coordination as the disease progresses. So that's what dementia looks like. And dementia is a neurocognitive disorder that impairs executive functioning. And executive functioning, in part, is the ability to make decisions and know that A follows B, which is followed by C, 2 + 2 = 4. So it's that kind of a decision-making process. It looks like it's a loss of memory, and that's a side effect of it. And that's usually how people it comes to people's awareness that somebody's affected by dementia. And what that is actually their inability to use executive functioning. Memory is steps of how to do things, typically. So the person can't remember where they were driving to, or they can't remember the steps it takes to cook bread, or whatever it is that they do in their daily life that they've done every day, and they all of a sudden or gradually can't do it anymore. So remember that dementia is a neurocognitive disorder. Delirium is a cluster of symptoms that comes on abruptly. The onset is very abrupt. It's usually hours and days. And there's symptoms indicating that there is an underlying illness that is acute and is dangerous. And so if you ever see anybody in the community who appears to have delirium, call 911 and get them to the emergency room. If you're doing an assessment with somebody in the hospital and they appear to have delirium, let the staff nurse know. So the onset is abrupt. The prognosis is good. It's very reversible. The course is fluctuating. It tends to be worse in the afternoon and evening. Um, People I've seen with delirium in the hospital, because I did medical social work for a while, um, they would have hallucinations and delusions in the afternoons and evenings, and when they're on certain pain medications. Percocet is kind of notorious as a painkiller for, in some people, developing delirium and having these hallucinations and delusions. Their sense of attention is impaired. They cannot attend to you or answer questions. Sometimes they're looking around. Sometimes they might be able to say words, but the words don't necessarily make a whole lot of sense. Their memory is impaired. A recent memory and immediate memory, like, what did you say 5 minutes ago? You know, in the MMSE, the mini mental status exam, you say 3 words, and then 5 minutes later, you say the 3 words again. They won't be able to remember it. Their perception of who they are and where they are is very impaired. That's why the word delirium is associated with the word delirious, right? We don't know where we are. We don't know sometimes who we are. We don't know what's going on. So the persons with a delirium, their psychomotor behavior can either be very quiet and kind of staring, almost like dissociation, or it can be very active. Um, the people I've seen in the hospital have tended to be more agitated. So they might be pulling at their cords and their tubes. They might be rocking in their bed. They might be banging. So be aware of that, but also be aware of the folks that are just absolutely still, and they're not unconscious, but they have impaired attention to the present moment and impaired perception of who and where they are. So then depression, you can see why these get confused frequently. It can either be gradual or abrupt, right? So it can look like dementia or delirium because it can be very gradual at times, or it can be very abrupt. The prognosis is variable, but usually good with treatment. The course is fluctuating and it's worse in the morning with depression. People tend to get better as the day moves on with depressed mood. Their attention, again, is variable. Um, it can be normal or it can be impaired. People with severe depression can have very impaired attention and not be able to track you or follow you asking questions. Memory, there is selective impairment in depression. People might not be able to remember details about a specific event that happened. That's why it's selective impairment. Um, or they might have an overall impairment of not being able to recall what happened when they were in a severely depressed mood. Their perception, though, is normal. They usually know who they are and where they are and what's going on around them. And then psychomotor behavior is a symptom of depression. It can either be retarded, slowed down, or agitated, speeded up. So this is just a quick one, particularly those of you who do hospital work, who are going to the hospital, so that you can know the difference between dementia, delirium, and depression. So questions, observations, if you have any about these, write them down. Feel free to email me if you have any questions. Take your questions about your clients to supervision and to any group meetings or group staffings you may have in your units. And again, the next training is in 2 weeks. It's going to be on January 21st at the same time. And we're exploring relationship issues and the things that contribute to having healthy relationships. So I hope you all have a good week. Take care of yourselves. Stay warm and stay out of the rain. Take care. Bye-bye.